right, I'm back. I'm Dr. Vinay Prasad here at University of California, San Francisco. I'm here for a roundtable discussion with two experts in multiple myeloma. I'm joined by Aaron Goodman. He's known as Papa Heen. He's at the University of California, San Diego. And I'm also joined by Dr. Manni Mohyuddin. He's an assistant professor at the Huntsman Cancer Institute in Utah and a well-known expert in multiple myeloma. Gentlemen, thank you so much for joining me to talk through these abstracts.
Thanks for having us.
Let's start with the first abstract. This is a provocative abstract that was presented at ASH. This is the impact of chromosome 1 abnormalities among patients with newly diagnosed multiple myeloma. It's my favorite kind of analysis, a subgroup analysis from the Endurance ECOG ACRAN E1 A11 trial. Manni, I wonder if you might start by giving us some historical perspective about high-risk cytogenetics, multiple myeloma. When should we be thinking beyond VRD? What's the history in this space?
Totally. So as you all know, VRD has been the historical standard of care for treatment of multiple myeloma. It still is a widely recognized standard of care. Our definition of high-risk cytogenetics and high-risk myeloma in general has been evolving. There are some classically well-recognized high-risk cytogenetic abnormalities such as deletion 17p, translocation 414, translocation 1416, 1420. GAIN1Q has been a little controversial. It's not formally recognized as part of our RISS high-risk staging. But and previous data seems to suggest that it was a big factor when it was associated with other abnormalities. But I think recently, based on some emerging data, the consensus of the field has been moving towards, yes, GAIN1Q, even without other coexisting cytogenetic abnormalities, is a high-risk feature. The other relevant question, a big controversial debate in myeloma is, KRD versus VRD. And I think that it's a topic that divides a lot of us. And just some historical perspective, KRD, based on non-randomized studies, seems to have done better than VRD, if you compare to historically how people have done with VRD, right? So lots of people before this trial was ran, and especially for high-risk patients, they were like, KRD is better than VRD. The reason why this trial excluded patients with most high-risk cytogenetics was that there was a parallel trial running that was ELO VRD versus VRD, right? That trial ended up being negative. That trial recruited patients exclusively with high-risk abnormalities. In this trial, the only cytogenetic high-risk abnormalities that were recruited were translocation 414, which is a well-known high-risk feature, and then GAIN1Q abnormalities. So that was kind of, everybody was expecting, for the whole myeloma as a whole, everybody was expecting KRD to be better. So I think people have had a little bit of tough time accepting that in this trial, KRD was not better than VRD. And I think people were like, okay, people still hold on to this, that, high-risk cytogenetics were excluded. And, so we don't know for high-risk cytogenetics, KRD is better than VRD. And I'd like to sort of, think about the biological plausibility of that hypothesis. And I think as we're going to discuss today, these subgroup analyses are very interesting. And there's a lot of questions about, biological plausibility, statistical power, and just holding on to our preconceived notions.
That's a great summary of where the field is at. And the only thing I love more than post-hoc subgroup analyses are historical controlled studies in multiple myeloma. So let the record state that. And when you're talking about 1Q gain, 3 copies is gain and 4 copies or more is amplification.
That is correct.
Why don't you give us a brief summary of what this trial showed? And then I want to jump to Aaron for his response to what he thinks, not this trial, what this post-hoc subgroup analysis of 1Q or chromosome 1 abnormality shows.
Yeah, totally. So I'm going to jump into that. But before I do, one very important fact, which I want to make sure everybody sort of captures, is that 414, which is high risk, was included in this trial. And 414, based on the original manuscript that was published, there was no statistical difference. If you look at the forest plot, VRD the outcomes were slightly better with VRD, not statistically significant. So that is why we're not seeing a 414 subset analysis, I'd argue, because with 414, KRD was no better. So with this particular subgroup analysis, they are looking at 1Q abnormalities specifically. And one of the first things they're doing is they're comparing 1Q abnormalities overall versus patients without 1Q abnormalities, regardless of whether they got VRD or KRD. And the data would seem to suggest that PFS was inferior for patients who had 1Q abnormalities. And there was a trend towards worse OS, but that was not statistically significant. Then they sort of go further into the types of chromosome 1 abnormalities, right? So they look at deletion 1p, and then they look at, gain 1q versus amp 1q. And they showed that for gain 1q, which, 3 copies, there was no there was a benefit for KRD compared to VRD. But if you look for amp 1q, the overall survival trended to be better with VRD compared to KRD. So there's really, in my mind, there's no way to biologically explain that. And when I kind of run into that situation, I'm like, are we just seeing statistical noise? But I'd love to hear what Aaron has to say about this.
Aaron, what do you think? Does the story make sense to you? What do you think about chromosome 1 abnormalities?
No, so it doesn't make sense. I want to just start with one little story. Like a year and a half ago, right when I was getting on Twitter, a KOL in myeloma, posted that they use KRD for induction, not if there's 3, but if there's 4 of these 1Qs. That's when they used KRD. I don't know where they got that, but that was their decision point for using KRD with 4. Now we go to this study that actually tried to look at it, post-hoc analysis. And as you said, with 3, not 4, with 3, they found that PFS was no better with KRD, but overall survival was better with KRD.
And what does that tell you? What is that? Is that classic treatment effect?
It doesn't seem like it, huh? Yeah.
It seems the opposite. It seems like it's selection bias.
So, and then when they looked at 4, there was no difference. But actually, the hazard ratio started to actually favor RVD for 4. So the bottom line is, I mean, this data, I commend. They were looking for something, and that abnormality does seem to do worse in general. I agree, but I don't think there's anything. I'm a clinician, and when I look at this, it was interesting, but there's nothing that I can use to make any sort of treatment decision. And I don't think anyone should be looking at this and go, well, my patient has 3, I'm going to use KRD. They have 4, I'm going to use RVD, or I just don't think that's applicable to the clinic.
Yeah, and I do think that the presenter in his defense was very balanced, and I don't think that they were trying to sell this agenda. I think they try to present the data as is, and the data is messy. I think we can sort of, all of us can conclude that. So I think people just like, this sort of reinforces people's, the notions they came in with, right? If I want to prescribe VRD, I will look at this and be like, hey, there's no convincing evidence that KRD is better. And I look at 414, another high risk feature. And from this study, KRD was no better than VRD for 414. And I think people who sort of have a ideological inclination towards using KRD will look at this data and find some reinforcement.
But Manni, this doesn't even matter anymore, right? We got quads now for induction. So
we're coming to that. That's the next one. So I guess closing thoughts on this topic, I would say this, that, if you believe something in medicine, that a newer drug is superior to an older established standard of care, I think you need to prove to me under what circumstances that is true. That means you pick whatever cohort you want, you run a randomized trial, you show me the newer drug is better. That never happened with KRD. We jumped on the bandwagon in the absence of that information. When we finally did run a randomized controlled trial, it surprised many of us because the older established standard of care VRD was just as good, if not better, because it has a better safety profile and it's been around longer and it's certainly more affordable. Now we do the post-hoc subgroup analyses. These analyses are only at best hypothesis generating. They're not good enough to hang your hat on. What you find here is something that, as you both point out, doesn't make a lot of biological sense. There's not the concordance between PFS and OS. It doesn't make sense. 3 copies, 4 copies. And for those reasons, I would take it with a huge grain of salt. I wouldn't change my practice based on these results. And I'm sticking to, you can mark it down for right now, I'm sticking to VRD until it proven otherwise. So thank you, gentlemen.